one of the orthopaedic registrars. Today I'm going to be presenting on displaced intra-capsular neck of femur fractures, when to fix and when to replace. So decision making regarding management of subcapital neck of femur fractures is based on a set of guidelines, and most commonly we use Gardner's classification system because this describes the degree of displacement of the fracture and therefore predicts the presence or absence of blood supply to the femoral head and ultimately the likelihood of survival of the live osteocytes within the bone. The most displaced fracture is the Gardner 4, which has no intact nutrients or neck vessels and therefore is very unlikely to be able to unite with fracture fixation. But even with Gardner's classification, there's no completely reliable technique to determine if the femoral head will be viable, and as a result, the standard approach to treatment currently is arthroplasty from the outset rather than reduction and pinning. There are multiple ways of managing neck of femur fractures. Firstly, there's non-operative management, and what that would involve is generally a period of protected weight bearing followed by serial imaging. Internal fixation is usually involves cannulated screw fixation or a DHS, and arthroplasty is usually in the form of a hemiarthroplasty or a total hip replacement. The questions that this presentation aims to answer include: is non-operative management suitable for this type of injury? When to fix and when to replace? Does the type of fixation matter? And in those undergoing arthroplasty, when should you do a hemi versus a total hip replacement? So first of all, can we non-operatively manage intra-capsular neck of femur fractures? We know that surgery is not without its comorbidities and risks, and so I wanted to see whether or not non-operative management would be a viable option. This was a paper retrospective cohort study which looked at 298 patients with a mean age of 82 and a mean follow-up time of 5 years. They found that secondary displacement occurred in approximately 30% of patients, and it occurred at a mean time of 16 days post-injury. They found that non-operative treatment was effective in 66% of patients with Gardner 1 fractures, and that the significant risk factors associated with secondary displacement included dementia, institutionalisation, a history of recurrent falls, and significant medical comorbidities. Pleasingly, 88% of community ambulators, those with a high baseline pre-op, achieved full recovery with non-operative management. So let's say we've trialled non-operative management and it's failed. Is there a difference in early versus delayed fixation? This was a retrospective study published in JBJS in 2002 with a 2-year follow-up looking at the results in patients who underwent early versus delayed fixation. Early was defined as within 12 hours of injury, and delayed was defined as greater than 12 hours. They found that the delayed group had a higher rate of going on to develop radiographical AVN, but there was no functional difference in early versus delayed, and that longer-term outcomes were unclear. For the displaced neck of femur fractures that require operative intervention, what is the outcome of internal fixation? Well, this was a study, an international RCT published in 2017, which looked at DHS versus cannulated screw fixation done between 2008 and 2014. Included 1,108 patients over the age of 50 with a 2-year follow-up, and they found that the reoperation rate for AVN was very equivalent between DHS and cannulated screws, 20% versus 22%. AVN appeared to be more common, slightly, in the DHS group, and that ultimately DHS was a better option for displaced fractures, basicervical fractures, and patients who are active smokers. Now, comparing internal fixation to arthroplasty, there's many papers published on this topic. We'll go through a few. The first is a JBJS article published in 2002, which was a prospective randomised controlled trial with a 2-year follow-up. It was a multi-centre trial in Sweden with 450 patients over the age of 70, and they found that internal fixation had a higher rate of failure at 43% compared to 6% in arthroplasty. Arthroplasty had better outcomes in terms of function and less pain, but there was no difference in mortality between the two. This article looked at 14 randomised controlled trials between 1996 and 2004 and included 2,289 patients, and their findings was that arthroplasty led to significantly lower major complications and reoperation rates, at 9 times lower compared to internal fixation, but once again, no difference in mortality. This article looked at arthroplasty versus internal fixation. Once again, found that arthroplasty patients had higher functional scores. Fixation patients had a 8-time higher risk of reoperation at 11.4 versus 1.4%, and that unfortunately arthroplasty patients had a higher risk of infection, blood loss, and operative time. These are some other papers which basically echo the results and the sentiments previously discussed. In summary, in patients over the age of 40, there was no difference in mortality between IF and arthroplasty. Internal fixation had a higher rate of revision, and that arthroplasty patients ultimately had higher functional outcomes. I wanted to know if there were any radiographical factors which can help us to predict if internal fixation is going to fail, and therefore which ones we should more likely do arthroplasty on from the get-go. This paper demonstrated that 4.1% of Garden 1 and 2 patients went on to develop AVN compared to 20% of Garden 3 and 4 which went on to develop AVN. So it's quite clear that we should really be only considering internal fixation in those who have undisplaced Garden 1 and 2 fractures. And interestingly, factors which were not significant for AVN development, according to this paper, included time to reduction and osteoporosis. This is an interesting paper which looks at the use of a posterior tilt on the lateral X-ray of the hip to estimate the risk of failure fixation in Garden 1 and 2 fractures. And they found that for patients with a posterior tilt of greater than 20%, 19% of these patients went on to develop fixation of failure, whereas in patients with less than 10 degrees of tilt, only 6% did. And so their sort of summary is that in patients with a posterior tilt of greater than 20%, these patients had a really increased risk of fixation failure, necessitating salvage arthroplasty. But even so, it still seems like arthroplasty patients have better outcomes, so is internal fixation still worth doing? This was a study which looked at outcomes between this new sort of novel FNS system which we have on the right compared to a 2-hole DHS. And they found that FNS patients had shorter surgical time as well as reduced blood loss and importantly a much increased union rate compared to DHS. This paper also looked at the FNS system and they found that patients who had undergone FNS had faster recovery and lower non-surgical complication rates such as shorter ICU stays and reduced blood transfusion requirements. So on the whole, what we've taken away so far is that arthroplasty has lower revision rates and better functional outcomes than internal fixation, but this is largely because they're comparing arthroplasty to traditional forms of internal fixation such as DHS or can screws. Rates of AVN are higher in 3 and 4, which are fixed rather than 1 and 2. This new system of internal fixation, which is the FNF, seems at the moment, at least in current literature and in short-term literature, to be superior to old forms of internal fixation, but that we need new and more long-term studies comparing FNS to arthroplasty to truly determine if one is better than the other. Now looking at hemiarthroplasty versus total hip replacements, I turned to the AOA National Joint Registry to look at our results in order to make some conclusions. This graph demonstrates that bipolar hemis have a lower rate of revision compared to unipolars within the first year and then after 3 years, but that it was equivocal within the 1 to 3 year post-op period. Found that bipolar hemis had a significantly lower rate of revision in patients under the age of 75 after 1.5 years compared to unipolar, and that for patients undergoing total hip replacements, fully cemented total hips had a lower rate of revision compared to hybrid and cementless for the entire period. And then when compared to hybrid, cementless had a higher rate of revision in the first 3 months only. Head size was important. Heads greater than the size of 32 mils had a lower rate of revision compared to 32 mils or smaller. And when used for neck of femur fractures, there was no difference in the rate of revision between dual mobility and standard acetabular components. It'll be interesting to see whether this is reflected in the current ongoing distinct trial. When comparing all comers, but for patients over the age of 70, bipolar hip replacements had a lower rate of revision compared to total hip replacements. The most this is broken down by age. We can see that in patients under the age of 70, bipolars had a slightly increased rate of revision versus total hip replacements between the 2 to 10 year mark. The most common reason for revision was dislocation at 33%, followed by fracture at 28% for total hip replacements. And that the summary points from the joint registry was that in patients undergoing hemis, bipolar had less revisions than unipolars, and the difference was even more pronounced in patients under the age of 75. For those undergoing total hip replacements, there was a higher rate of revision than for those undergoing hip replacement for OA. Most common reasons for revision included early dislocation and fracture. For those over the age of 70, hybrid or cemented had a higher rate of revision compared with cementless. Use hybrid or cemented, as these have a lower rate of revision compared with cementless. Use a bigger head for a lower dislocation rate, and that dual mobility or constrained liners don't have a high revision rate in NOFs. Then I also looked at this paper, which was published recently in 2022 by Wayne Hoskins et al. Looked at revision rates for neck of femur fractures in hemis versus NOFs. And basically the findings was that there was no difference in revision rate for dislocation between total hip replacement and hemi, but that the main reasons for total hip replacement revision differed between men and women was dislocation for women and periprosthetic fracture for men. And the main reasons for hemi revision included long-term issues such as chondrolysis, acetabular erosion, and chronic pain. So their recommendations was to offer hemiarthroplasty to men above the age of 75 and women above the age of 80, to offer total hips to women below the age of 75, and then to offer a total hip or a hemi based on life expectancy in this middle ground area. So the take-home messages from today is that for undisplaced neck of femur fractures, under the age of 60, offer internal fixation. You can trial non-approved management, but these patients would require close radiological and clinical follow-up. For those over 60 or under 60 and with little ambulatory capacity, offer arthroplasty. For those non-displaced in the elderly or with a posterior tilt of greater than 20, offer arthroplasty. And when offering fixation, FNS for now appears to be a superior option to DHS or cannulated screws, and that fixation within 12 hours may reduce asymptomatic AVN. In terms of for arthroplasty, for those who are medically infirm or non-community ambulators, offer a hemi. For those who are community ambulators under the age of 75, offer a total hip replacement, which is hybrid or cemented using a large head. And for those over the age of 75, offer a hemi or a total based on their life expectancy and medical baseline. This has been a large, lengthy presentation, so I hope that everyone is still awake. Thanks very much for paying attention. These are my references, Thanks very much.